Okay, thank you, Manus, for the invitation and for the great congress and great organization. These are my consultancy, not related to this talk. So, about history, we already heard in the last presentations. We know that the material change, the characteristic of the prothesis change. It's difficult to say what will be the future. The only things that we can say that in the future we will still have a lot of work with prothesis, because if you look at the life expectancy, for example, on your right diagram, we saw that the life expectancy for the females in the 1840s was like 45 years old, and today we are around 80 years old. According to the mathematical analysis, we saw that in the next 40 years, around 350% of the patient more will be over 85. So still place for the prothesis. Today we can say that we are in the RSR era. Why? Because the reverse shoulder have probably the most predictable result. This picture shows all the different types of protheses that today are available in Europe. All of them work in the same principle, so Gremont principle. So how we can still improve, how we can do something more. Today we know everything about material, about the base plate, about how many screws we need, when we can put the glenosphere. The only thing that we can still improve is precision. So the more precise we will be, the less problem we will have. Everything starts with the planning. Every surgery must start with the classical planning, with the radiographs, with CT. Today also the 3D CT can say that it's a gold standard. Most of the companies already gives you, together with the prothesis, some program with which you can plan. Yes, for the more difficult cases, we need more precise planning where we can move, change positions, and this planning is the one who will really help us. For example, this is a case of a young girl, septic arthritis when she was a child due to vaccination. This vaccination didn't go into the muscle but inside the joint. And we plan to perform a reverse stemless. And this is the second planning we did. And we find that the smallest stemless component for the humerus was too big. So fortunately, we find this. Can you imagine what can happen if you find this intraoperatively? So for this patient, we will plan to do a biplanar osteotomy, revision stem, try to perform straight humerus, but this procedure will be in March. So what is one step forward, 3D reconstruction? One step forward is so-called PSI. Enrico already told about that. This means patient-specific instrumentation. This means so-called 3D printed JIGS. So according to the CT of the patient, we print some plastic instrument that we put over for example, humeral head or the glenoid that guide us how and when to put the K-wires, the screws, and like that. So one step forward, JIGS, is navigation. Unfortunately, in shoulder, we still don't have enough data to say that this really helps. Surely it helps for the more difficult cases. We can just say, for example, from the knee arthroplasty, where they had mixed conclusions, and for the basic primary arthroplasty, they say that there is no difference. How is in shoulder? It's, as I say, difficult to say. What is one step forward that? One step forward is so-called PSN, so prothesis-specific navigation. So if you produce one tools that is possible to take it over, I don't know, a guide of a key wire of one specific prothesis, like, I don't know, Lima. And if you have some problems you have during the operation to change to, I don't know, to Johnson, you just change the guide for the navigation you put on the prothesis, and you can change between different protheses. So this is the way how we work. If it's possible, we perform over arthroscopy to see how and when happened. This is a case of failed resurfacing, probably not enough release of the posterior inferior capsule. Go inside the joint, find this. Firstly, perform a 3D CT. According to 3D CT, we plan where to put the prothesis, where to put the screws. One sonda we put inside the scapula of the patient, and then we match what we have on the patient and what we have in the computer. Matching we perform by putting like 40 different points in different area of the patient, of the glenoid. It takes like 5 minutes to perform this step. Then we match what we have on the patient and what we have on the computer, and then with jig that we put on, this is for example a guide of a K-wire, we know to touch where exactly we are. So we can simultaneously look at the computer and at the patient. So for the most difficult case, it's a very good tool. So for example, here on the left low, look, here, you can see that we, by changing the position of our tool, we can see exactly how much bone, if we are in the bone or if we are outside. As I say, for the difficult case, it changed everything. So when to perform this navigation with this complex system? As Enrico before said, this is just a tool to help us. Okay, people like Enrico, like Offer, probably they will never need this. But mostly of the surgeons who don't perform every day prosthesis, having this a good alliance. So this is one patient I operated 3 weeks ago. It was a relatively young girl, 50 years old. 4 operation on the shoulder, locked posterior luxation. They perform hemi in extreme anteversion, and then there was a completely destroyed of the glenoid. This is a 2D planning. Surely we perform a 3D plan. Problem with prothesis that was already inside, so we have a lot of confusion. So we need more precise planning. And what we found out, almost completely retroverted, I don't know, 80 degrees of retroversion of the glenoid. So the glenoid was like just a ridge. So it wasn't a plate, but a ridge. In this case, the navigation helped you a lot, I can tell you. Plan we did. It was a case for a reverse, surely because it's several years luxated. How much we can rim, in which position we can put the base plate. With the navigation was very easy. The operation went very fast. In 1 hour, we perform a procedure that normally can take us, I don't know, 3-4 hours, just because of the difficulty how to put the glenoid. So this is the matching, the things I told you before. Wait a few minutes, put one sonda, this one, as we use as a retractor, usually in the subscap area, and then by finding the right position, this is for the K-wire, we know exactly where we are, what inclination we need in all the direction, and we can also look at the patient because we are balanced in the on the computer and on the patient in the same way. So this is a picture of the procedure. For example, in the case we put a screw of 40 millimeters. By hand, this is very difficult. So the more precise operation we perform, the more we reduce the risk of the complication of the dislocation. And for the young patient, as Enrico said, this is crucial because they probably will need further operation. So what is the future? Yes, there is still some future. Now we are working on one research together with the University of Civil Engineering, where we try to find some mathematical formula where is the ideal position to put the reverse. How? By studying the deltoid. So by studying the thickness, the EMG characteristic, the anatomy of the insertion, the bone anatomy of the humerus and of the scapula, and according to the 3D CT, the PSI, PSN, make a calculation. It will be very nice to see because I found one professor who all his life is dealing with the lever arm. And he said to me, how you can do all your life just shoulder problems? And I respond to him, yes, how can you deal all your life just with lever arms? And he said, together we will try to do this calculation. So thank you, and I would like all of you and mostly your physiotherapists to my congress in July, where we try to focus on the hot topics now on the rehabilitation in shoulder. Thank you.